Good morning, everyone. I'm delighted to welcome you all today. Today, we'll be discussing an important topic: WHO guidelines on surgical site infection prevention. This presentation will cover key strategies and best practices to reduce infections after surgery. We'll explore guidelines, practical tips, and the latest recommendations from WHO. So, let's get started and learn how we can improve patient safety together. Today, I want to highlight a key reference from Lancet Infectious Diseases, 2016, which underscores the importance of preventing surgical site infections, or SSIs. These infections are actually among the most preventable healthcare-associated infections we encounter. That's a critical point because it shows that with the right measures, we can make a real difference. SSIs pose a significant burden worldwide, affecting both low and high-income countries. No matter the setting, they impact patient outcomes and healthcare resources. Recognizing this, the World Health Organization has prioritized developing evidence-based recommendations for preventing SSIs on a global scale. Our goal is to implement these strategies universally to improve patient safety everywhere. This slide sets the stage for understanding just how vital it is to focus on prevention and how global guidelines can help us achieve better outcomes. So, the guideline development process we're discussing here was published in Lancet Infectious Diseases in 2016. It's a solid example of how WHO develops their guidelines using established, rigorous methods. First, they conduct systematic literature reviews to gather all the relevant evidence. Then, they combine that with expert consensus to interpret the data. To ensure the quality of the evidence, they use the GRADE methodology, which helps them rate the strength and reliability of the findings. Based on this process, recommendations are classified into two categories, either as strong or conditional. This structured approach helps ensure that the guidance provided is both evidence-based and transparent, which is essential for making informed decisions in public health. Connecting this to the overall theme, it highlights the importance of a rigorous, standardized process in developing trustworthy guidelines that can be confidently implemented worldwide. According to a 2016 study published in Lancet Infectious Diseases, the World Health Organization identified 13 key preoperative measures to help prevent surgical site infections. These recommendations address several important areas, including how we prepare the patient before surgery, strategies for decolonization, the use of antibiotic prophylaxis, and how we properly prepare the surgical site itself. In this overview of preoperative recommendations, we'll explore how each of these components plays a crucial role in reducing infection risk. By following these guidelines, we can significantly improve patient safety and surgical outcomes, which ties directly into our overall focus on infection prevention. Let's go through some key points from the WHO preoperative recommendations. First, regarding immunosuppressive agents, in most cases, it's advisable not to discontinue them before surgery. Maintaining their use helps prevent complications related to the patient's underlying condition. Next, nutritional support is important, especially for underweight patients. Providing adequate nutrition can improve healing and reduce infection risks. When it comes to preoperative bathing, plain or antiseptic soap can be used. Both are effective in reducing skin bacteria. Nasal decolonization with mupirocin is also recommended, particularly for patients colonized with Staphylococcus aureus, to lower the risk of surgical site infections. Regarding bowel preparation, oral antibiotics combined with mechanical bowel preparation is preferred, but mechanical prep alone is discouraged because it doesn't provide enough protection. For hair removal, the key is to avoid unnecessary shaving, which can cause skin abrasions. If hair removal is needed, clippers are the safest choice. Timing of the surgical antimicrobial prophylaxis, or SAP, is crucial, ideally administered within 120 minutes before the incision to ensure optimal tissue concentrations during surgery. For surgical hand preparation, either soap or an alcohol-based rub works well. The goal is to reduce skin flora effectively. When preparing the surgical site, alcohol-based chlorhexidine gluconate, or CHG, is preferred due to its superior antimicrobial activity. Lastly, the use of antimicrobial sealants is not recommended, as current evidence doesn't support their effectiveness in preventing infections. All these measures, when followed properly, contribute to reducing the risk of surgical site infections and improving patient outcomes. This slide doesn't contain enough information. That's why we're moving to the next slide. This slide doesn't contain enough information. That's why we're moving to the next slide. Let's talk about perioperative immunosuppressive agents. According to a study published in Lancet Infectious Diseases in 2016, it's important not to discontinue immunosuppressive medications before surgery. Many might think stopping these drugs could reduce the risk of surgical site infections, but in fact, doing so can backfire. Discontinuing immunosuppressants may lead to a flare of the underlying disease or even reduce the effectiveness of the medication when restarted. This is a conditional recommendation, meaning it's not a one-size-fits-all answer. The decision to stop or continue these medications should be personalized. It's crucial to involve the prescribing physician, the patient, and the surgeon in this decision-making process. Overall, the key is to balance the risks, preventing infections versus avoiding disease flare, and to tailor the approach to each individual patient's situation. This careful consideration helps optimize surgical outcomes while maintaining disease control. Let's take a closer look at the role of nutritional support in surgical outcomes. As highlighted in Lancet Infectious Diseases, 2016, the nutritional status of patients can significantly influence their immune response. When patients are malnourished, their ability to fight off infections after surgery can be compromised. This means that improving their nutrition before surgery can make a real difference in preventing post-operative infections. Early nutritional support is particularly beneficial for those who are severely malnourished or have experienced significant injury. For example, using oral or enteral formulas that are enriched with multiple nutrients can help improve recovery in underweight patients undergoing major surgery. However, it's important to note that this recommendation is conditional and based on very low-quality evidence, so it's not a one-size-fits-all solution. Implementation might also be limited by factors like cost and availability of these specialized formulas. Overall, enhancing nutritional support is a promising strategy to improve surgical outcomes, especially in vulnerable patient groups, aligning with our broader goal of optimizing patient recovery and reducing complications. Today, I want to highlight the importance of preoperative bathing or showering, which is considered good clinical practice. The main goal here is to ensure that the skin is as clean as possible before surgery, which helps reduce the bacterial load, especially around the site where the incision will be made. This step is crucial because a cleaner skin surface can significantly decrease the risk of infection post-surgery. Patients are advised to bathe or shower using either plain soap or antimicrobial soap. Either option is acceptable. Although the evidence supporting this practice is categorized as moderate quality, the recommendation is conditional, meaning it is strongly advised, but also takes into account individual circumstances. Overall, this simple yet effective measure plays a vital role in infection prevention and aligns with our overarching goal to improve surgical outcomes and patient safety. Let's talk about nasal decolonization, which is a key strategy in infection prevention. As highlighted in Lancet Infectious Diseases in 2016, Staphylococcus aureus is one of the most common pathogens associated with healthcare-related infections worldwide. It can lead to serious issues like post-operative wound infections, pneumonia acquired in hospitals, catheter-related bacteremia, and in cases where it's resistant to methicillin, it can significantly increase the risk of mortality. One important risk factor we know is nasal carriage of S. aureus. If a patient carries the bacteria in their nose, they're more likely to develop these infections later on. That's where decolonization comes in. Mupirocin nasal ointment, which is usually applied twice a day for about 5 days, has proven to be effective, safe, and relatively affordable. When used alongside a whole-body wash, typically with chlorhexidine gluconate or CHG, it can significantly reduce the bacteria in the nasal passages. In practice, for patients undergoing cardiothoracic or orthopedic surgery who are known nasal carriers, using mupirocin 2% intranasal ointment, with or without CHG body wash, is strongly recommended. The evidence supporting this approach is moderate, but the recommendation is strong because it helps prevent infection in high-risk surgical patients. So, implementing nasal decolonization strategies like this can be a crucial step in protecting our patients from these potential infections. Let's talk about mechanical bowel preparation, or MBP, and its role in colorectal surgery. Typically, substances like polyethylene glycol and sodium phosphate are used preoperatively to help clear out the intestinal and colonic contents. The goal here is to induce the patient to void these contents before surgery. The main reason we do this is to reduce the risk of postoperative infectious complications. By decreasing the amount of fecal material inside the bowel, we're also lowering the bacterial load within the intestinal lumen. This makes sense because fewer bacteria mean a lower chance of infection after surgery. In addition to MBP, oral antibiotics are often given together with the preparation. This combination is used to further cut down the bacterial load inside the gut, providing an extra layer of protection. Research shows that when we use preoperative oral antibiotics combined with MBP, it significantly reduces the risk of surgical site infections in adult patients undergoing elective colorectal procedures. In fact, this approach is recommended with a moderate level of evidence and is considered a conditional recommendation. On the other hand, just doing MBP alone, without antibiotics, is not advised. The evidence suggests that MBP by itself doesn't provide enough benefit in reducing infections, so the strong recommendation is that we should not rely solely on MBP without antibiotics. So, in summary, combining oral antibiotics with mechanical bowel preparation is the best strategy we have to minimize postoperative infections in colorectal surgery. When it comes to hair removal in patients undergoing surgery, the main recommendation is that hair should either not be removed at all or, if it absolutely must be, it should only be done with a clipper. Shaving, on the other hand, is strongly discouraged in all situations. This is because shaving can cause microscopic trauma to the skin, which significantly increases the risk of surgical site infections, or SSIs. This holds true whether the hair removal happens before the operation or during the procedure itself. The evidence supporting this recommendation is of moderate quality, but the consensus is clear. Avoiding shaving helps minimize skin trauma and reduce infection risks. So, the key takeaway here is to be very cautious with hair removal methods. Preferably avoid shaving altogether to promote better surgical outcomes and patient safety. Successful surgical antimicrobial prophylaxis, or SAP, relies on delivering the antimicrobial agent in effective concentrations directly to the operative site. This is typically achieved through intravenous administration. Timing is crucial here. Administering the antibiotic at the right moment ensures it works effectively during the surgery. It's recommended to give SAP before making the surgical incision when it's indicated, and this depends on the type of operation. The evidence supporting this is strong, although the quality of that evidence is considered low. The goal is to administer the antibiotic within 120 minutes before incision, but it's important to also consider the half-life of the antibiotic being used. For example, if the antibiotic has a short half-life, timing becomes even more critical to maintain effective tissue concentrations during the procedure. Additionally, intraoperative reducing should be considered if the surgery lasts longer than 2 half-lives of the drug, or if there's significant blood loss. This helps ensure that effective antimicrobial levels are maintained throughout the operation, reducing the risk of infection. Overall, the optimal timing of SAP is a balance. Giving it too early or too late can compromise its effectiveness, So careful planning and consideration of the specific antibiotics' properties are essential for successful prophylaxis. When it comes to surgical hand preparation, the key point is that it should be done thoroughly to minimize infection risk. The recommendation is to either scrub with a suitable antimicrobial soap and water or use an alcohol-based hand rub, often called ABHR, before putting on sterile gloves. This step is crucial because it helps reduce the microbial load on our hands, which is essential for maintaining a sterile environment during surgery. The evidence supporting this practice is of moderate quality, but it's considered a strong recommendation because of its importance in infection prevention. Ultimately, choosing between scrubbing or using an alcohol-based hand rub depends on the situation and your facility's protocols, but the goal remains the same: ensuring our hands are as clean and disinfected as possible before gloving. This practice ties into the overall theme of maintaining sterility and patient safety throughout the surgical process. Let's discuss surgical site skin preparation, specifically the use of antiseptic solutions. The recommendation here is to use alcohol-based solutions that are based on chlorhexidine gluconate. These are strongly recommended, although the evidence supporting this is considered low to moderate in quality. It's important to highlight that alcohol-based solutions should not be used on neonates, as their skin is more sensitive and vulnerable. Additionally, these solutions must not come into contact with mucous membranes or the eyes due to potential irritation or harm. We also need to exercise caution because alcohol-based antiseptics are flammable, so proper handling and storage are essential. When using chlorhexidine gluconate solutions, be aware that they can cause skin irritation, so careful application is necessary. Moreover, they should never come into contact with sensitive structures like the brain, meninges, eyes, or middle ear to prevent serious complications. Overall, choosing the right antiseptic and applying it correctly is crucial for reducing infection risk during surgery, aligning with our broader goal of ensuring patient safety and optimal outcomes. Now, let's talk about antimicrobial skin sealants. These are sterile, film-forming sealants based on cyanoacrylate. They are usually applied after the standard skin preparation at the surgical site and right before making the skin incision. The idea is that they stay in place and act as a barrier, preventing bacteria from migrating from the surrounding skin into the surgical site. They gradually dissolve over several days after the operation, helping to reduce the risk of infection. However, current evidence suggests that using these antimicrobial sealants specifically to reduce surgical site infections is not strongly supported. In fact, the recommendation is conditional, and the evidence is considered very low quality. So, while they might seem helpful, we should be cautious about relying on them solely for infection prevention. This ties into the broader theme of evidence-based practices. It's important to weigh the benefits against the current evidence when considering such interventions. Today, I want to highlight some key points from a 2016 study published in The Lancet Infectious Diseases, which emphasizes the importance of intraoperative and postoperative measures to prevent surgical site infections. The World Health Organization identified 16 critical strategies, and these cover a broad range of factors that can significantly influence patient outcomes. These measures include ensuring proper oxygenation, maintaining optimal body temperature, and controlling blood glucose levels, each of which plays a vital role in supporting the immune response and wound healing. We also need to pay attention to fluid management, the use of appropriate drapes, and meticulous irrigation techniques to reduce contamination. The choice of sutures and the management of drains are equally important, as they can impact infection risk and wound healing. Finally, the duration of antibiotic prophylaxis, or SAP, should be carefully managed to avoid unnecessary exposure while still providing effective infection prevention. Overall, these intraoperative and postoperative recommendations form a comprehensive approach that, when followed diligently, can dramatically lower the incidence of surgical site infections and improve patient recovery. This aligns perfectly with our overarching goal of delivering safer, higher quality surgical care. Let's go through some of the key intraoperative and postoperative recommendations highlighted in the Lancet Infectious Diseases article from 2016. First, maintaining adequate oxygenation with an FiO2 of 80% has been associated with reduced infection rates, so ensuring proper oxygen levels during surgery is crucial. Next, keeping the patient normothermic is important because hypothermia can impair immune function and wound healing. Blood glucose control is also vital. Tight regulation helps prevent infections, especially in diabetic patients. Fluid therapy should be carefully managed to avoid over or under resuscitation, which can impact patient outcomes. When it comes to drapes and gowns, adhesive drapes are not recommended, as they do not provide additional benefit and may even increase risk. Instead, standard draping techniques are sufficient. Wound protectors are recommended to help reduce contamination during surgery. For irrigation, povidone solutions are advised rather than antibiotics, as they effectively reduce bacterial load without promoting resistance. In high-risk cases, negative pressure wound therapy can be beneficial, helping to promote healing and remove excess fluid. Using antimicrobial-coated sutures is another strategy to lower infection risk at the incision site. Interestingly, laminar airflow systems are not recommended, as evidence does not support their efficacy in reducing infections. Regarding drains, they should be used judiciously. There's no evidence that they prolong surgical antimicrobial prophylaxis, so they can be removed when no longer needed. For dressings, standard dressings are recommended, and there's no need for advanced types like hydrocolloid, silver-impregnated, or hydroactive dressings unless specifically indicated. Again, no prolongation of antibiotic prophylaxis is advised with these measures. Finally, these recommendations align with WHO guidelines for intra- and postoperative care, emphasizing simplicity and evidence-based practices to minimize infection risk and promote optimal recovery. This slide doesn't contain enough information. That's why we're moving to the next slide. This slide doesn't contain enough information. That's why we're moving to the next slide. This slide doesn't contain enough information. That's why we're moving to the next slide. Let's take a look at some important guidelines from Lancet Infectious Diseases. When adult patients are undergoing general anesthesia with intubation, it's recommended that they receive 80% FiO2 during the surgery itself, and for about 2 to 6 hours afterwards. Now, why is this important? Adequate tissue oxygenation at the surgical site plays a key role in preventing surgical site infections. High levels of oxygen in the blood, achieved through administering high-concentration oxygen, help ensure that the tissues around the incision are well oxygenated. This is especially critical at infected tissues, which tend to have lower oxygen tension compared to non-infected areas. Better oxygenation at the site can enhance the oxidative killing capacity of neutrophils, which are our body's first line of defense against infection. The overall recommendation here is strong, based on moderate evidence, highlighting that perioperative oxygenation is a valuable strategy to reduce the risk of infections post-surgery. This connects to our broader theme of optimizing perioperative care to improve patient outcomes. Lancet Infect Dis 2016, 16, E288-303. Hypothermia is defined as a core temperature less than 36 degrees Celsius. It frequently occurs during and after surgical procedures that last more than 2 hours. This happens because anesthesia impairs the body's ability to regulate temperature, and it's often combined with exposure to the cold environment of the operating room. Unintended hypothermia is considered an adverse event of both general and regional anesthesia, and it can be associated with several complications. These include increased cardiac complications, more blood loss due to impaired coagulation, slower wound healing, decreased drug metabolism, reduced immune function, and a higher risk of surgical site infections. To prevent this, It's important to use warming devices during surgery to help maintain the patient's normal body temperature. This is a conditional recommendation, supported by moderate evidence. Maintaining normothermia during surgery is crucial for patient safety and recovery, and it ties into the overall goal of improving surgical outcomes. Let's take a closer look at the relationship between blood glucose levels and surgery. As shown in Lancet Infectious Diseases, 2016, a rise in blood glucose concentration is commonly observed during the operative and post-operative periods. This happens because of a surgical stress response, which triggers increased secretion of catabolic hormones like catecholamines and cortisol. These hormones not only raise blood sugar, but also inhibit insulin secretion and cause insulin resistance. Now, observational studies have consistently shown that hyperglycemia is associated with a higher risk of surgical site infections, or SSIs, in both diabetic and non-diabetic patients. This highlights the importance of managing blood glucose levels around the time of surgery to reduce infection risk. This brings us to the concept of intensive perioperative glucose control. It's suggested for both diabetic and non-diabetic adults, and while the recommendation is conditional with low evidence, it is based on the potential benefits. Specifically, tighter glucose control has been associated with decreased SSIs. However, there is a caveat. Intensive glucose control can increase the risk of hypoglycemia. That's why close and reliable monitoring of blood glucose concentrations is absolutely crucial when implementing this approach. In summary, managing blood glucose carefully during the perioperative period can make a significant difference in infection outcomes, but it requires a balanced approach to avoid hypoglycemia. In a study published in Lancet Infectious Diseases in 2016, researchers looked at sutures with antimicrobial properties. The main idea here is to prevent microbial colonization of the suture material itself, which can be a real source of post-operative infections. Triclosan-coated sutures, in particular, have been suggested for use across all types of surgery, given their potential to reduce infection rates. Now, it's important to note that the recommendation for using these antimicrobial-coated sutures is conditional, meaning there's moderate evidence supporting their use. So, while they aren't universally mandated, they are considered a valuable tool in our infection prevention toolbox. This ties into our broader theme of improving surgical outcomes and minimizing infection risks, especially in procedures where infection can significantly impact recovery. The use of antimicrobial sutures like triclosan-coated ones represents a promising step forward, but we should always weigh the evidence and consider the individual patient context. Let's talk about drapes and gowns used during surgery. The panel recommends that either sterile disposable non-woven drapes and gowns or sterile reusable woven options be used to help prevent surgical site infections. It's a conditional recommendation, which means the evidence supporting this is moderate to very low in quality, but the goal is to reduce infection risk. Now, an important point is that plastic adhesive incised drapes, whether they have antimicrobial properties or not, should not be used. The evidence for this is low to very low, and the recommendation is conditional against their use. Overall, choosing the right drapes and gowns is a key part of infection prevention strategies in surgery. Selecting appropriate sterile barriers helps protect patients, but we need to be mindful of the evidence quality behind these choices. Let's talk about wound protector devices, also known as wound edge protectors. These are typically made up of a non-adhesive plastic sheath that's attached to either a single or double rubber ring. The purpose of this setup is to securely hold the sheath in place around the wound edges. By doing so, they help facilitate retraction of the incision during surgery, which can make the procedure easier and more manageable. Most importantly, these devices are designed to minimize contamination at the wound edges during abdominal surgeries. This is a key point because wound contamination is a major factor in surgical site infections, or SSIs. The panel suggests that we consider using wound protector devices in certain types of surgeries, specifically clean contaminated, and dirty abdominal procedures. The goal here is to reduce the rate of SSIs, although it's worth noting that this is a conditional recommendation based on very low-quality evidence. So, while the evidence isn't definitive, the potential benefit of these devices in reducing infections makes them worth considering, especially in higher-risk surgeries. This ties into our overall theme of how we can improve surgical outcomes and patient safety through thoughtful use of available tools and techniques. Let's talk about incisional wound irrigation. The panel suggests that using an aqueous povidone-iodine solution to irrigate the wound before closing might help prevent surgical site infections, especially in clean contaminated wounds. However, this is a conditional recommendation, and the evidence supporting it is considered low quality. So, while it could be beneficial, we need to interpret this with some caution. On the other hand, the panel recommends against irrigating incisional wounds with antibiotics before closure. Again, this is a conditional recommendation, and the evidence is low, so there's not enough support to justify routine use of antibiotics in this way. As for saline irrigation, unfortunately, there's just not enough evidence to say whether it helps prevent infections or not. Overall, these points highlight that wound irrigation practices vary, and the evidence isn't strong enough to make definitive recommendations across the board. It's important to consider each case individually and stay updated as new research emerges. Let's move on to this important point about antimicrobial prophylaxis when a wound drain is present. The panel suggests that we should not continue perioperative antibiotics simply because there is a wound drain in place. This is considered a conditional recommendation, and the evidence supporting it is of low quality. Essentially, this means that, based on the current data, stopping antibiotics in this context is generally reasonable, but there's some uncertainty. They also recommend removing the wound drain when clinically indicated, which makes sense because prolonged drainage can increase infection risk. However, they found no solid evidence to define the best timing for wound drain removal. So, while we know it should be removed when necessary, the exact optimal timing remains unclear due to very low-quality evidence. Overall, this emphasizes that antimicrobial use in the presence of a drain should be carefully considered, and clinical judgment plays a key role. It's a reminder that the decision to continue or stop antibiotics, and when to remove a drain, should be individualized based on the patient's condition and the clinical situation. Let's discuss postoperative surgical antibiotic prophylaxis prolongation. The panel recommends against extending antibiotic use after the surgery is completed, primarily to prevent surgical site infections. The main concern here is the widespread risk of antimicrobial resistance, which is a serious and growing problem. This recommendation is considered strong, even though the evidence is moderate in quality. However, there are specific cases, such as cardiac and orthognathic surgeries, where continuing antibiotics might have potential benefits. But importantly, we need more high-quality, well-designed, randomized controlled trials to really understand if prolonged antibiotic use in these situations is justified. Overall, the key takeaway is that extending antibiotic prophylaxis after surgery generally isn't recommended due to the resistance risks, but ongoing research could clarify if there are exceptions, especially in complex surgeries. This fits into the broader theme of optimizing antibiotic use to ensure patient safety and combat antimicrobial resistance effectively. Let's take a closer look at the key points from this slide. The Lancet Infectious Diseases article from 2016 emphasizes that WHO recommendations are based on solid evidence and are meant to be applicable across different regions worldwide. However, implementing these recommendations isn't a one-size-fits-all process. It requires adapting strategies to fit local contexts and specific community needs. The focus should always be on high-impact, feasible measures, especially in low-resource settings where resources are limited, but the need is great. This approach ensures that interventions are both practical and effective. To sum up, while the guidelines provide a strong foundation, Success depends on tailoring them to local realities and prioritizing measures that can make the biggest difference in those settings. This aligns with our overall goal of improving health outcomes in a realistic and sustainable way. Let's talk about some of the key implementation challenges we often face. First, resource availability is critical. This includes essential supplies like oxygen, chlorhexidine gluconate, mupirocin, and the necessary devices. Without these resources, it's hard to maintain effective infection prevention measures. Next, training and adherence of surgical teams are fundamental. Even with the right resources, if the team isn't properly trained or doesn't follow protocols consistently, the risk of infections increases. Continuous education and monitoring are vital to keep everyone on the same page. Finally, surveillance and data feedback play a crucial role. Regular monitoring allows us to identify issues early, track progress, and make data-driven adjustments. Without good surveillance systems, improvement efforts can stall or become less effective. Overall, these challenges highlight that successful implementation isn't just about having the right tools. It's about ensuring resources, training, and data systems work together seamlessly to improve patient outcomes. Let's take a moment to look at some key references that support these updated guidelines. The first one, by Allegranzi and colleagues, focuses on new WHO recommendations for preoperative measures to prevent surgical site infections. This emphasizes the importance of proper patient preparation before surgery, including skin antisepsis and appropriate antibiotic timing. The second reference, also led by Allegranzi and Zaid, expands on intraoperative and postoperative measures. It highlights strategies like maintaining sterile environments, proper wound management, and continued infection control practices after the surgery is done. Together, these references underscore a comprehensive approach, starting before surgery, during the operation, and after, to effectively reduce infection risks. They're crucial for guiding best practices and ensuring patient safety across all phases of surgical care. This slide doesn't contain enough information. That's why we're moving to the next slide.